sustain, sustaining HIV gains locally, South to South strategies amid its shrinking donor space. So today I'll be your moderator. My name is Diana Tibesigwa. I serve with AIDS Healthcare Foundation as the Regional Policy and Advocacy Manager for East and West Africa. And my specialty is policy. I'm a policy analyst. And I've done a couple of papers, moderated high number of high-level policy dialogues on health, sexual reproductive health, social protection, and I currently lead 7 countries in policy and advocacy in the East and West Africa with AIDS Healthcare Foundation. I'm honored to be here and to lead this conversation. Some housekeeping. Sometimes we get to hear some speakers get open. So if we could keep our phones and laptops mute, not until we've given opportunity to speak. If you experience any technical issues, please reach out. Lizzie is on standby and the team. And like she mentioned, this session is recorded. And after the session, I think the link will be shared with all the participants who are on this call. Thank you for logging in. And Lizzie, thank you for giving us that brief background to this conversation. In my lifetime, I have never seen a confused and disorganized development space like it is currently. And mainly, it is hitting the health sector. As we have this conversation, I think it is important for us as we speak about HIV funding, it is also for us to have a mind about the entire health sector because it is not just affecting HIV, but the entire health, including those sectors that are intersecting with health or HIV. Just to take us into context, as we gather here today, it is essential for us to reflect on the progress made and challenges ahead. If we look at our current global report that we have about HIV, I know you're familiar with these statistics, but re-echoing them helps us to kind of set the environment and keep on reflecting on what we have done and what are the gaps and what are the threats currently that are threatening the gains that we have achieved. So globally, we have 39.9 people living with HIV. New infections have declined, according to the UN AIDS report, by 39% since 2010, with 1.3 million new cases of HIV as of 2023 report. The HIV-related deaths are reported to have dropped to about 69% since 2024, since 2004. However, the epidemic still persists. Still, the same reports indicate that over 50% of people living HIV globally are in this region. So we are discussing East and Southern African region. 60% of the new child infections worldwide occur. And then we also have the challenges of our adolescents, especially the girls and young women who are 3 times more likely to acquire HIV than their male peers. Despite the gains, the threats currently, we're seeing donors shrinking, insufficient domestic financing, policy barriers, stigma, humanitarian crisis, which kind of jeopardizes the sustainability of the gains that we have attained in the HIV space. I need to remind our listeners and all the speakers that as we speak about the shrinking donor space and anything to do with domestic financing, it is to remind ourselves that we have actually been grappling with governments to increase health financing towards the different components, within health. The current situation where donors are reprioritizing and shifting, their priorities to something else. It is something that we've been grappling with. So the challenge is before us right now. And so this conversation today, the webinar it has 4 objectives. And one is to share innovative practices and scalable models in response to emerging challenges in HIV programming in the SA region, foster peer learning by exchanging research, advocacy strategies, and institutional success stories, strengthen member visibility and collaboration through interactive and partner-led sessions, and then identify cross-cutting trends and priority areas to inform future programming and policy engagement in the HIV response. So that's the 4 areas will be our main focus for this conversation. And straight away, we have a number of speakers, including 2 keynote speakers. One will be coming through, and then the other we shall play a video because they were unable to join us for this call, but at least they've taken the initiative to share their communication and insights about the theme of the webinar. I would like to this note introduce to you Dr. Maurice Atoki, CEO, ABC Health Nigeria. Maybe before she comes, I can still briefly talk about Dr. Maurice. He's the Chief Executive Officer of the Africa Business Coalition for Health, a not-for-profit coalition of Africa business leaders working with key stakeholders to support health sector improvements across the continent. She also serves as the facilitator of the Health Policy Commission at the Nigeria Economic Summit Group, a graduate of Harvard Business School, London Business School, and Yale University. Maurice holds advanced degrees in law, finance, business administration, with a career spanning both public and private sector. She sits on several boards and is deeply committed to youth empowerment, sustainable development, and effective service delivery. Without wasting time, I would like to take the honor to invite Dr. Maurice to deliver the keynote to our listeners and speakers. You're welcome, Dr. Maurice.
Thank you so much, Diana, and thank you for that very glamorous introduction. And Lisa, thank you. Thank you for inviting us once again to this very important discussion, especially at the times that we're in, even more important than it's ever been. So you do have my slides, don't you? Otherwise, should I share?
Please share. Please, you can share your screen.
Okay. If you can see it, please kindly indicate.
Yes, yes.
You can?
Yes. So you can just go to presentation mode. Should be good.
All right. I just did that. So, wonderfully, I've been asked to talk to the private sector roles amidst the AIDS crisis, the HIV. We're talking about the HIV as AIDS, but of course, the very notorious situation we're all saddled with at the present, which is the AIDS that we've been all privileged to, if I may use that language, over time on the continent of Africa, that has seemingly now come to an almost 100% stall. Today, we're going to look at a couple of topics. We're going to look at the shrinking donor landscape generally and what is at stake to start with. So if we look at the declining global HIV funding trends, let me save bandwidth. Sorry, just a minute there. And I'll go on off camera. Okay. Yes, please. A minute. Okay, I think I need to reshare now. Can you still see my presentation?
No. You stopped sharing, yes.
Now?
Yeah. Just go to presentation mode. We should be fine. Great.
Okay.
Yeah.
So now just really focusing on the HIV funding trends at a global level, talking about PEPFAR, the Global Fund. I'm sure most of us are familiar with it already. And over the years, all of the funding that has been coming into the continent, over time, it shrunk again due to shifting donor priorities and competing crises. HIV wasn't priority when COVID came up in 2019, even though it continued. But sources like PEPFAR and Global Fund um, continued to be that, back end support that really made such a pandemic, if we may say, in HIV, really seemed to disappear, unlike how notorious it was uh, over time in the last like 10, 20 years. And what we've seen in the last couple of years is that the world suddenly woke up to the possibility of pressures and financial demands on their own specific countries and had to have a rethink. So I think generally, uh, COVID was an awakener to the international community. The reality that COVID could happen just made those organizations or institutions or countries, if you may say, rethink. Now, what is the impact on some of these interventions that we've seen so far? There's funding cuts, uh, threatening access to ART, HIV testing and prevention, tools like PrEP and condoms. And what that does is it really put everybody who's been a victim, unfortunately, at a very, very severe exposure and putting also millions at the risk of access and of losing vital services. Now, we also face the risk of reversing progress. We've made as a continent a lot of progress as far as HIV is concerned, but of course, thanks also to all of those supports through the donors that we had received. If we may look at the positive side of it, of course, there are also the very concerning sides. But these are also at risk without local solutions. We knew from time that we couldn't sustain or maintain most of those interventions. Africa knew, and I recall that a couple of months, let's say maybe over a year ago, I was beckoned on by the UN AIDS community in my country, Nigeria, to galvanize the private sector so that they could also be a bigger part of the situation and they could be, informed enough to make decisions about how to intervene in the treatment um, of HIV/AIDS and so on and so forth. And so this graph also just talks about the donor funding for HIV in Africa between 2005 and 2005 and 2024, just last year. You can see how it moves. In 2005, it had, a peak on the gray chart, bar chart in 2019, declined a little bit more after 2019 and after we kind of got away, 2014, after we got away from HIV, and then went into 2019, declined a little. Unfortunately, what we're facing now between 2020 and 2024 seems to be at almost the peak we experienced in 2014, and it's been consistent. And that is not good news. Since then, there's been gradual decline since 2014, with $7.86 billion recorded in 2024. So the red bars emphasize the urgency and the significance of sustained funding to maintain progress in the HIV response across Africa. So when we narrow in into the USAID funding cut, what exactly are we talking about? It's not news, but maybe just to remind us. Early in this year, the US administration implemented substantial reduction in foreign aid, including over 80% cuts to USAID multi-year contracts. Now, what this decision has done and this announcement is really disrupted HIV services across several countries, especially in Africa, who apparently also enjoyed the donations. Now, WHO has listed Nigeria, that's country specific, among 8 countries likely to run out of supply HIV treatment soon. And I can only think that the reason why that is so is that there weren't the statistics and the situation on ground did not show the readiness of Nigeria to pick up, assuming the interventions of the donors actually, came to a halt. It also listed countries facing the risk to include Haiti, Kenya, Lesotho, South Sudan, Burkina Faso, Mali, saying that these countries could exhaust their supply of HIV treatment in the next few months. Now, according to the Global Health Agency, the countries now face 10 million additional HIV cases and 3 million HIV-related deaths. As of March, 164 health facilities had shut down due to funding shortages, and I believe this is Nigeria as a case study. And without urgent intervention, over 20 more facilities will close by next month. That's some really pretty disturbing news. And if you just step back a little to talk to what this means, locally, is that the horrors that we faced when HIV became known and popular, where you will literally see emaciated human beings in public places, is likely to come back. In the last couple of years, I mean, a layman can tell that that wasn't the case. So you couldn't even really tell because of the presence of the interventions and the antiretroviral medicines. Um, you couldn't really tell who was being treated for HIV or who wasn't. Now let's look at the South to South imperative in a contextualized response manner. Now there are 10 countries who account for almost half of new HIV infections. The ones that are highest estimated share of worldwide new HIV infections as at 2021 include South Africa at 14.0%, Mozambique at 6.5%, Nigeria at 4.9%. And I'm going to only talk to the African countries here. Tanzania at 3.6%, Uganda at 3.6%, Zambia at 2.5%, and Kenya at 2.3%. And so you need to also be a bit more contextual about your thoughts around this. Think about Nigeria, a population of over 200 million citizens, people. 4.9% of that is relatively high. So we talk about new infections in 2000 at 2.9 million and in 2021 at 1.5 million. And the rest of the world, 51.1%. Now, as donor funding is shrinking, countries in the global south now need to collaborate to drive locally owned HIV responses tailored to shared realities. And just like, we experienced the pandemic in 2019, we can tell that one of the reasons the world was able to get rid of the pandemic, COVID-19, the way it did, was because we realized that we were in a global village. You couldn't just really claim that, you were in some faraway country in Europe or in another continent in Australia, and you couldn't be impacted or infected. The world has been so interwoven that everybody's business is everybody's business. And so the question is, why now? Cooperation enables the exchange of practical tested solutions. The reality is that if we don't collaborate, we will lose. We will lose out in social, economic. We will lose out in, so many diverse ways that we've not even had the opportunity to perhaps even think through. Um, it's critical now because it also fosters political solidarity and collective actions. Uh, Again, I mean, I want to still believe that the reality and the shock of COVID-19 is one of the reasons, if not the main reason, why USAID did what it did. Now, when we talk about Brazil, South Africa, joint efforts in local drug production and tech transfer will be a major case example. And in Nigeria, advanced local ARV production to reduce dependency on import. Again, considering the high population, there is no way we could ever think importations will be sustainable. I mean, that's beyond what anybody can assume. Now, the key opportunities unlocks shared learning, regional supply chain, and access to technology, strengthening health systems and ensuring sustainability. Again, if we look at the impact on South Africa, we look at the cessation of PEPFAR, which can result in additional 150,000 to 295,000 infections in another 3 years, potentially leading to over 500,000 deaths in the next 10 years. When we look at Nigeria, um, now we have reduced community testing and halted outreach programs. I personally know those who were involved in healthcare outreach programs that have had to sit at home. The government, as we speak, we also know has allocated $3.2 million to procure HIV treatment packs in the tune of 150,000 over 4 months to mitigate the impact. The question is, how is this sustainable? How do we see, again, I mean, I'm aware that the Nigerian government could never have claimed um, that they did not emphasize uh, the situation or something similar to the aid being halted like it did. Because 2 years ago, I was part of a forum where these conversations were being had, and we had state government being represented. And I remember one of the commercial states in Nigeria laying claim that they have matching personnel, HR personnel, community health workers who were able to take on the kind of roles that the donors actually had already taken on in those interventions. So when we look at another country like Uganda, distribution of antiretroviral drugs and HIV test kits has also been disrupted due to reliance on US funding partners, typically affecting service delivery at lower health facilities. Now, again, private sector. What is the role of private sector? I'm from a very robust coalition of private sector drivers in Nigeria, so made up of private health sector and private non-health sector. I know that in Nigeria, there is the Nigerian Business Coalition Against AIDS called NIBUCA, majorly organized to harness private sector competencies and resources and mobilize them to complement government effort in combating HIV/AIDS. Now, more than ever, this is the time when NIBUCA needs to really step up and come and walk their talk. Across the continent, ABC Health is leading regional private sector engagement in health. We advocate sustainable financing. We advocate largely public-private partnership. The reality that it does seem like PPPs are one of our, how do you call it now? Low-hanging fruit, no matter how complex it seems. As a continent and as individual African countries, we do need to deeply consider going far with private sector partnering with public sector. So again, we also drive local production of health commodities and corporate-led HIV response strategies across multiple African countries. Now, we're not the health experts. What we do is that we do a lot of um, consulting. We do a lot of collaboration and strategic partnerships. We do a lot of listening to understand specific disease burden areas. But more importantly, how we can aggregate private sector competencies to ensure that we make a difference and we improve health outcomes across the continent of Africa. So we work a lot with business leaders, letting them understand what the size of the gaps are and helping them to make informed decisions about how to intervene or engage as far as improving health outcomes are concerned. On a global level, we know about foundations like Elton John 8 Foundation, who have launched emergency funds to fill these gaps led by the withdrawal of US aid, ensuring continuity of service. Generally, if we look at private sector and why we must all think private sector as a replacement for this withdrawal of funds that has happened to the continent, is that we must realize how result-oriented private sector is. So as a health community, we must begin to visualize. And I'm not saying that there won't be hurdles, there won't be concerns. Private sector is used to a particular way of doing things, not, wanting to interfere with their profits. Oh my God, am I off?
No, you're on. We're just
You're
trying to
on.
summarize.
Oh,
Yes.
yes, because I saw Liz's call coming. Right, again, yeah. So talk about the innovative financial power of the private sector or private players generally. Also, the local manufacturing capacity that is inherent in private sector. I mean, we're seeing the booming digital health solutions another world entirely, maximizing multi-sectoral partnerships, which also is a place we have to pay a lot of attention to. And then, of course, workplace HIV programs now needs to be on the rise. HIV testing, treatment access, the reality of HIV living amongst us, and so on and so forth. So these are just also PP for pool procurement and cost sharing, impact investing and catalytic capital, health insurance model with HIV coverage, DFIs, the risk and investment. Now, we also talk about creating enabling ecosystems for private sector involvement. I mentioned it earlier, and I'm just going to summarize it. It's important that Africa realizes, both its government and its communities, that the way private sector is structured and have been structured because they want to generate profit. And so now there has to be deliberateness in terms of things like tax incentives, in terms of policies, in terms of regional economic communities, and giving them exposure in a good way, to understand all of these regional structures and how they work to harmonize rules and to support private sector interventions. Again, what are the lessons from some of the models? MTN, HIV workplace program, and Albert's lab investments will be covered. The youth, as we know, Africa is known to be a youthful population. We are the largest youthful population in the world. And what that just really continue to do what it has to do, and we have to be double ready to be able to combat it. And youth-driven HIV innovation hubs should be deliberate. Gender responsive programs should be deliberate. We know how culture also makes women to be exposed as far as HIV is concerned, and inclusion of MSMEs and informal sector in the whole engagement process is critical. The informal sector is the largest, occupies as far as Africa is concerned. So it's not the model of it has to be really localized to suit the African peculiarities. So this is about the metrics and how they matter, accountability and impact tracking. This is one thing we don't do so well at, and this is one thing that the donors USAID particularly did well, and I hope the times that they spent with us, we've been able to understand. I do know that Bill and Melinda Gates also does this really quite well in their models. Um, our indicators need to be sharp. We need to track financial investment, the programs themselves. We need to collaborate between public and private sector in terms of cross-sector data sharing. We cannot just, pretend that we're going to do what the foreigners have done. Data is powerful, and they needed data, and they have leveraged data. They've taken our data away. How are we using those data? Are we even capturing data in the first place for immediate and future R&D purpose? And lastly is the ESG alignment. Aligning HIV initiatives with ESG standards will ensure responsible, sustainable, and corporate contributions. What is our call to action? We must build a locally led, market-driven HIV ecosystem. Private sector must be deliberately included in the narratives and as stakeholders in all of these engagements and interventions. We must mobilize political will and business leadership. We must strengthen South-based coalitions, and we must align all of these interventions and solutions with the UN SDGs and UNITS. That is the language of the world, and we must be deliberate about including it. In conclusion, the future of HIV response is local. It's time for the private sector to step into a legacy defining role. It's time for you and I to make the private sector understand its responsibility, but also create an ecosystem that is enabling for the private sector to fit into their role. And in the face of donor retreat, we must advance, we must not retreat by building resilient, innovative, and inclusive health ecosystem. I thank you for your very esteemed attention.
Thank you, Dr.
Thank
Moore.
you.
Thank you, Dr. Maurice, for that informative presentation. It sets ground for this conversation. It was rich in data and also providing status, but also forecasting what would happen in the future, just in case we are not able to respond immediately. But we also appreciate the different alternative financing models and programming models that you have shared with us that we could actually leverage on as countries if we want to respond or cover the gap, that has been caused by the current crisis. It is so interesting that the 10 countries that you have highlighted in your presentation as some of the countries that account for the half of the infections. If we go back and track how the funding trends for those countries have been, maybe South Africa would stand out because when it comes to their HIV response, I think about between 75 to 80% of their HIV response is covered by domestic resources. But the rest of the countries that have been highlighted in there, 73% of their funding towards the HIV response has largely been funded by donors. And we cannot imagine what would be happening right now. But interesting statistics that we have over 10 million additional new HIV cases, but also the 3 million HIV-related deaths within this period of disruption. That poses a threat on us as Africa. We need to be reminded that we have also been grappling with the poor health system. And so we need, like you mentioned, to come together. We need political will. We need to agree to move forward as Africa. You have highlighted a number of approaches. Some we have actually been trying in terms of local production of medicines. Countries you've highlighted, Uganda, I think Uganda does, some bit of production of ARVs, Kenya. Some countries are starting, some are doing diagnostics, but they also face challenges. However, we have experts on this call who are going to delve into, expounding on the possibilities of our countries being able to take on some of the recommended researched approaches that we could adopt to kind of help us, get out of the deep pit that we have been thrown in. But yes, let's proceed. I would like to now request Lizzie to play for us the video for our second keynote. And I'm hoping that it is short enough to allow us progress with our program. Thank you, Lizzie. Over to you.
Hello, I'm Dr. Kate Talenko of Corvus Health. It is my honor to speak with you today about regionalization, accountability, and lean operations. We have experienced a major shock in the global health world. USAID has been shut down, the US is pulling out of the World Health Organization, and European donors are dramatically reducing their funding. We must mourn the loss of the global aid world, but briefly, but then turn to acting and creating a new, better world. This shock is an opportunity to upend the flaws of the old system. We must break down the silos of the old system and implement regionalization. Africa will have a population of 2.4 billion people by 2050, and even now it has a significant market to drive healthcare demand. For many health services, including specialty services, we are going to need to pool resources and start regional programs. This will enable us to achieve economies of scale so we can provide high quality care for all. As an example of regionalization, Corvus Health, along with Zenith Global Health and others, are partnering to launch an African digital cancer pathology platform. This service will enable oncologists or pathologists anywhere in Africa to send digital slide images to African cancer pathologists to get accurate diagnoses and start their pathway to treatment. This is also an opportunity for communities to demand accountability from their governments. It can be done. My team and I have helped DR Congo and the Dominican Republic remove thousands of ghost workers, hire new workers, and provide care to tens of thousands of people. Every ghost worker you remove and replace with a real worker means hundreds of people have access to healthcare. And you can do the same with pharmaceuticals. It's estimated that 30 to 35% of medicines are lost or stolen between central medical stores and the final clinics. Every bottle of antiretroviral pills that you keep in the system represents hope for another month for someone living with HIV/AIDS. And how we plan services will have to change. We can't start programming and planning the same way we used to do, thinking about how many people we're going to employ, how many computers are we going to buy, how many cars are we going to buy. We need to practice lean operations. We need to start with the number of people we want to serve and determine what's the most efficient, sustainable way to provide them care. It won't be the way we provided care last year. We'll use telemedicine, team redesign, and the power of communities. My team and I are helping Nigeria and Cote d'Ivoire redesign their cancer teams and make them more efficient. Instead of a single oncologist caring for a few hundred patients, a well-supported oncologist can provide high-quality care for over 2,000 patients. So thank you so much for the work that you do. We look forward to hearing from you and how you plan to regionalize, drive accountability, and use lean operations. Take care.
Sure. Thank you, Lizzie. We appreciate the keynote from our keynote speaker. And I think she continues to really emphasize some of the things that the previous keynote speaker mentioned about. But what comes out strongly in this is that we need to leverage on things that we have been previously ignored, like digital health, telemedicine, of course, a part of the digital health. She continues to still emphasize the element of leveraging with the private sector, and also mentioning that we don't have to do business as usual, that we cannot continue doing business as usual in a shrinking donor space where we are almost failing to raise domestic resources. We need to change the narrative. But the question is, what is the game changer? And how can that change, happen? Who should be involved? And how do we all come together to contribute to that? At this point in time, I would like to get to the next session of this webinar. We have panelists. We have a panel discussion that is going to delve into the theme, but also reflecting on the keynote address from the two speakers. We have 4 panelists. we have Mr. Munyarandis Chimwara, the country coordinator, Compass Coalition in Zimbabwe. And he will mainly speak about domestic financing and sustainability efforts across the region. We have Petrida Paul, Chief Strategist under Imara Leadership Initiative in Tanzania. He also help us get to know what does the financial landscape as an economist look like soon for CSOs and communities. Our other speaker is Maxwell Changombe, and he's an SRHR program coordinator under Restless Development in Zimbabwe. And he'll be delving on how do we bridge the funding gap in HIV programming for children and youth. Our speakers, highly experienced. I would really wish to speak to their specialty so that we get to appreciate what they bring in this conversation. Allow me, because some of these names I cannot tell if this is male or female, but Mr. Munyarandis Chimwara, the country coordinator for Compass Coalition in Zambia. He coordinates partner campaign efforts to promote quality and affordable healthcare and services, while with a background in advocacy, communication for development, and social science, recognizing the critical role of advocacy in Zimbabwe's healthcare and service delivery landscape. Munya, actually he had now cut off his name. Munya joined efforts by other leading advocates to drive change in health delivery to address gaps in domestic funding for health, barriers to access SRH, health equity and equality. Then Petrida Paul serves as the chief strategist in Imara Leadership Initiative in Tanzania, where she provides strategic direction to the institution's program delivery in the country. She currently sits as the co-chair of RBM Partnership to End Malaria Youth Workstream. In her previous role, she worked as a youth engagement consultant for the African Leaders Malaria Alliance. The biography is very long, but because of the time, I will really cut it short, but I thought I would speak to their specialty. Maxwell Changombe is a passionate youth advocate and program coordinator for advocacy, accountability, and meaningful youth engagement and restless development. He currently leads a regional project focused on enhancing access to SRHR services for young people through SR ministerial commitments and other regional framework. Maxwell has expertise in a number of things which I may not mention, but as they deliver on their questions, I think we'll be able to appreciate the speciality that they bring on board. So without wasting time, I would like to invite Munyarandis Chimwara from Zimbabwe kindly speak to the domestic financing and sustainability efforts across the region. You're welcome.
Good morning, good afternoon, colleagues from across the world. And thank you very much, Diana, for the beautiful introduction. So I'm speaking to efforts by CSOs working in HIV and health in Africa. We have come together under a coalition called Compass to bring regional expertise across the continent to make sure that resources for health are made available. If you look at how we have, in the last few years, sustained gains in the fight against HIV, it becomes very important and imperative for Africa and the rest of the world to sustain gains in the fight against HIV, especially with a shrinking donor landscape and the recent United States government stop work order pronouncements, and this response requires us focusing on local solutions and strengthening partnership within the Southern Hemisphere. And let me add that this also involves leveraging local expertise, resources, and models for HIV prevention, treatment, and care. It might also mean at times exploring new financing mechanisms and reducing reliance on external aid. So in 2001, and I'm sure most of us are familiar with this, that the African Union set a target of allocating at least 15% of the national budget each year to the health sector, known as the Abuja Declaration. And as recently as February 2023, African leaders recommitted to implementing that declaration target. And unfortunately and sadly, in 2020, only South Africa had met the budget, and we are yet to see another country moving up to that target. Now, just a closer look at what Zimbabwe has done. The government of Zimbabwe, like many countries in the South, has been working on enhancing its ability to finance HIV programs internally, reducing dependence on external aid. And there is impetus in country now, especially after the withdrawal of funding from the United States government. The government has also taken significant steps to boost domestic funding for its healthcare systems. Some of these include the famous health levy, which has been a best practice, with countries from Africa coming to look at this, raising almost $10 million. We also have a sugar tax, which has been generating almost $18 million to strengthen the country's health system. We are currently working on a national health insurance, which seeks to provide more stable funding for healthcare. And this is a game changer for us in country, as we have seen a number of citizens spending more out of pocket support for health. But sadly, despite these efforts, Zimbabwe still faces challenges in meeting the Abuja Declaration target of allocating 15%. So we have been pushing as a coalition for increased domestic resource mobilization to improve access and quality. We have also been pushing for improved funding predictability. Funding flows are crucial for effective healthcare planning and delivery. We want to make sure that healthcare is front-loaded with the resources ahead of the implementation of any annual budget, so that at least in between budget cycles, facilities remain funded. As a coalition also, we have been pushing for transparency and accountability, which are essential for efficient use of healthcare resources. And this is key given some of the resources that I've spoken to that have been earmarked for health. And we are also, and I'm glad Dr. Maurice in a keynote spoke about the involvement of private sector, and I think motivation for tax credits so that companies can then venture into increased philanthropy through social corporate responsibility becomes also key. Now, in terms of what we can do, South-to-South collaboration, and I know I have one of our colleagues who is on the call. Let me see if I can pick his name, Beyin from Ethiopia, asked how African CSOs can work together. And I think it's important to learn from what Campus has done. So Campus is a South-to-South coalition of civil society organizations working in Uganda, Malawi, Tanzania, and Zimbabwe, with technical support from our partners in the North. And the idea is to link and learn, also share experiences, share best practices, and collaborate in resource mobilization to implement various programs to sustain health funding and leverage on shared experiences, resources, and expertise among countries in the global South. So we have been looking at disease prevention and control, collaborating on disease prevention initiatives such as sharing best practice, conducting joint research, and implementing coordinated public health campaigns. And these are key to make sure that as Africa and countries in the global South, we are able to collaborate and share best practice and ideas on how best we can move forward. And I know in terms of production of essential medicines, I think it's important, again, Dr. Maurice spoke to this, we need South-to-South collaborations that can facilitate the joint production of procurement of essential medicines, reducing costs and providing access to life-saving treatments. Can you imagine African Union choosing one country that can be responsible for producing medicines for the whole of Africa? And all the other African countries can then support that country with expertise, resources, human resources as well, including financial resources, so that at least we can get medicines, essential medicines for that matter, from within Africa. This also would then mean pulling procurements so that at least we can increase spending and cost efficiencies. Now, there's also a very important element around workforce development. Zimbabwe has been losing its human resources for health to South Africa, Rwanda, Botswana, Zambia, and in recent years, the US, Ireland, Australia, and traditionally the United Kingdom. And I think this is a realization that we are producing good nurses and doctors, and I think it's important that as an African continent, in the spirit of South-to-South collaborations, we then begin to look at how best we can leverage on countries that have been producing expert services in various disciplines within health to then find ways of making sure that those doctors and nurses go to where there is need across Africa. I remember Zimbabwe a few years back receiving expertise from Cuba. We had a lot of nurses, doctors were coming in from Cuba. These were bilateral arrangements that were being made between Cuba and Zimbabwe, and I think it's something that we also need to continue looking at. Then also there is cross-border collaboration, which is important, public health experience sharing. Now, in terms of what we can do around global commitments and local solutions, community system strengthening, I think it's important to empower communities to take ownership of their health and well-being by building their capacity to manage and deliver health services. And as campus, we have partners who have been working on direct service delivery models around rollout of art in communities so that at least citizens and community members do not have to travel long distance to facilities. We have also strengthened engagements with communities in the planning, implementation, and monitoring of health programs to ensure that needs and priorities are addressed. Again, capacity building, we have a strong cadre of community health workers, community-based organizations, and other stakeholders who have been able to deliver health services and manage health programs. And a lot of the community-led monitoring initiatives in country in Zimbabwe were being undertaken by community-based organizations. Health financing, exploring new financing mechanisms such as community-based health insurance, and also promoting innovation through indigenous knowledge systems. We need to tap into the strengths that our communities have in terms of mobilization, engagement, and making sure that we bring expertise from our tradition. So thank you very much for this opportunity to speak. Over and out.
Sure. Thank you. Thank you so much for sharing lessons from Zimbabwe. I know Zimbabwe is one of those countries that are innovatively coming out to find avenues and solutions to their health systems. And we appreciate the taxes that they're coming up with. You mentioned the health levy. We have repeatedly had that coming in from Zimbabwe on the different platforms, sharing, how they're trying to devise means in raising more resources, from the citizens, but something that would widen or expand on the resource envelope for the health sector. We've heard about the national health insurance, and one of the questions that keep on coming in my mind is that what is taking African countries so long, for us, to all of us, all our countries, to have national health insurance. In some countries, it has actually demonstrated a well-coordinated healthcare system. Currently, I have countries that I know, like Rwanda, where the leaving of the US funding, has not had a huge impact on the community, just because they have been able to put up strong systems, financing systems in place. And I think these are some of the things that we need to learn from, the countries that we need to learn from, the lessons that we pick from other countries, so that we are able to kind of scale up across the region and be able to respond to, to the current challenges. I also wanted to mention, you mentioned about 15%. That's interesting because Abuja has been here for ages, and it is also so ashaming that we don't have a country in Africa that has attained the 15%. I think the highest has been 13, 14, and the rest are falling below 7. We are still grappling within 4, 6, and none of us has been, committed to allocate. And all that comes out of political will. So when we start speaking about financing, the share to the health sector is determined by the political will. When you see a 6% allocated to health, just know that that may not be a priority for government. So I think it's high time that we got into holding ourselves accountable. We have the 15%, we have the LM commitments that have just been made this year, still by our leaders, but moving from rhetoric to action is one of the things that we suffer, as Africa. And I think with all these lessons that are coming in, our donors leaving, I think it's high time to look within and be able to implement things that we have put in place to sustain our healthcare system. I want to invite our next speaker to speak to us, and that is Petrita Paul, the Chief Strategist, Imara Leadership Initiative in Tanzania. And please share with us the financial landscape as an economist looking at CSOs and communities, because we know that CSOs have demonstrated to be an extended arm of government, including the communities. And the previous speaker spoke about us strengthening communities. This is something that we are losing because also CSOs have been relying so much on donor funding, and everything is falling within the cracks. So kindly share with us, the landscape, and probably can also share what we need to do for us not to lose out those structures, the CSS and the communities. Yes, Pedrita Paul, please come on board and speak to us.
Thank you so much, Diana, and a very good afternoon, good morning, colleagues, from wherever you're joining. As Diana mentioned, my name's Petrita Paul, and I'm a Chief of Strategy at Imara Leadership Initiative. So ideally, as much as has been mentioned by the previous speakers and colleagues, I'll just touch a bit on the overview of HIV funding trends and the shrinking donor context. So since I think beginning of this year, it's been evident that there is an increase in declining international funding because of many donors pulling out, especially the huge hit by the USAID funding matters that have been actually cut down and highly affecting the health sector in general. However, since we've had major global HIV donors, such as PEPFAR and the Global Fund and other bilateral donors that have also been reduced funding, this has highly affected how the distribution and disbursement of funding has been in most countries globally, but with a hard hit effect being in Africa. And so what's the reason exactly? So I think apart from the fact that we have this shift of global priorities, for instance, lots of elements of peace and securities, and maybe the assumptions that countries will start generating their own funding so as not to be donor reliant. And maybe there might be a donor fatigue issue that is also affecting the global north. We still think that despite the fact that this funding contents have been reduced, there's still room for CSOs and communities members to actually make an impact. And this is through different community interventions that our CSOs are working together with the government, looking at the different government port fundings that is allocated and generated in country to support CSOs and different stakeholders working on the HIV sector, and we've seen still that most of CSOs are still providing HIV treatment and support to key population services through outreach activities. But I think also the fact that despite there being a limited stock take of the funding, and everyone is grappling on what's actually available, CSOs are actually coming to work together in coalition so as to ensure that there's a bigger strategic focus on treatment that will cascade, for instance, the use of PrEP, the use of viral load suppression, and also risk that to be able to have that risk exclusion. But despite the fact that there's a high impact of interventions that have been affected due to the limited cost efficiency and a lot of data-driven programs being reduced. I think this also creates an opportunity amid different crises whereby we actually have global funders that are pushing for a shift of funding to local CSOs. And I think we've seen this through different coalition groups. I'll mention a few that are actually mobilizing, such as Impact Sante, the RBM partnerships and malaria itself, and the Global Fund itself is still working with different coalition partners. So I think it's a chance also for local community members to actually be able to know and meet the different shifts so as they can reduce the long-term effects of that are affecting the different community at the moment. But I think there's a huge opportunity whereby you can actually what we are also doing to integrate universal health coverage and health system strengthening in collaboration with the interlinkage of HIV systems. And whereby, since we are going to look at the broader HIV funding increasingly tied to universal health coverage, primarily healthcare system. This means that at the CSO level, that the HIV work within the broader health equity and concept at community level will actually be curbed through different multiple channels that are available. But I think the broader context comes to how best domestic resource mobilization can be mobilized. We've seen this in the context of malaria elimination, whereby we had different countries from Africa actually pledge a certain amount of funding to ensure that there is a curb of malaria cases. As you know, if someone has any disease and you add HIV to it, that creates double the effect of diseases. So I think domestic resource mobilization is key, and actually through our governments, they can be able to actually reduce the effects of donor dependency that most of countries do have. But I think lastly, I'll just mention about the concept of having results-based financing. And what do I actually mean by results-based financing? This is actually a system whereby you actually have performance-based grants that are actually given to CSOs, but they adapt to different models whereby they create sustainability effect. So for instance, you have a CSO that's receiving a grant on supporting for HIV elimination. The CSO could look at a broader concept of investing in local manufacturing, whereby we can actually have medicines that are generated from a country, or we can actually have all the products that one needs that are going to be manufactured in a country. Because at the end of the day, when we complain about the reduction of donor funding and affecting HIV sustainability of services and support, it's because majority of our communities, majority of our countries relies on the products from the external world, we don't have enough sufficient manufacturing industries that can produce the medicines that actually people need. So once we create the results-based financing to ensure that we have enough pharmaceutical companies to actually support majority of the people, not only on a concept of HIV, but generally through several diseases, we can actually be able to not really feel the effect of the shrinking donor landscape, but be able to actually create a sustainable mechanism for all. Thank you, and back to you.
Sure, thank you, Petrita. We're running out of time, but those are interesting insights in regards to CSOs and the community. I like the fact that you mentioned that we still have opportunity as CSOs to raise resources. They are willing donors and funders who are willing to fund community-based organizations. But just maybe to mention that certain aspects of funding, I think like someone mentioned in the previous, that we cannot do business as usual. There are countries that are completely doing away with disease financing. Like where I'm based right now, you cannot start talking about HIV, as a standalone. They're moving into integration, but we can still borrow. Like what did disease-based financing like do in terms of improving local resource mobilization? Then people have spoken about issues to do with insurance, but we still have countries that are still performing poorly. Even when they have insurance, we still have high out-of-pocket expenditure. You highlighted the issue of universal health coverage. That is actually a commitment and a target under the Sustainable Development Goals. And if we did an analysis on how we're performing as Africa in regards to attaining universal health coverage, we are still not performing well. So in terms of also result-based financing that you spoke about, I think most of the African countries have adopted the result-based financing model, but I think it's been mainly implemented in governments and has not yet crossed to civil society. And for civil society, I think it's been dependent on who is funding you and which result-oriented modality that they were actually focusing on. However, these are good suggestions that would help us, look through and analyze and assess and see if they deem fit within the context that we serve within our respective countries. But also maybe to mention, lastly, I bring in the last speaker, that we have also had like cost-benefit analysis done, where researchers have been able, for example, to do a cost-benefit analysis to tell that if you invest so much in preventing this kind of disease, you can avert and save this amount of money. If you do more support, let me say investment in production and promotion of condoms, these are the HIV infections that you will have averted. These are the resources. So we have all that, available. The question is, how much have we used data to inform, our planning, our decisions, and all that. I would like to invite our last speaker, who is Maxwell Changombe. She's or he is a NESAR HR program coordinator at Restless Development, and he is going to help us discuss how we can bridge the funding gap in HIV programming for children and the youth. You're welcome, Maxwell, and we request you to kindly use minimal time to allow us conclude within the stipulated time. Thank you.
Thank you so much, Diana. I hope I'm audible enough that
Yes,
you
you're
can hear me.
audible. Yes, you're very audible.
Great, great. So yeah, like mentioned, my name is Maxwell Changombe, and I'm the programs coordinator with Restless Development, and I'm based in Zimbabwe. It's really good to meet you all and talk about issues that are affecting young people. So particularly want to look at how we can bridge the funding gap in HIV programming for children and youth. We can just say for young people in general. So as we look at it from previous speakers, I think they've mentioned some of the key points that we really needed to put across that can help us. But I also want to look at a different angle, looking at funding for those small organizations, community-based organizations, small CSOs in our communities, youth groups, organized groups that are there, formally registered and non-formally registered. How can they keep working? You know, these are the ones that are mainly affected. Because if you look at it, we are looking at bigger organizations now vying for those small funds, small pots of funds that are coming up through different trusts and foundations. So we really need to look at that and how best they can work on that. I really like the point from the previous speaker where they noted issues to do with the results-based funding. I think that's something that we can also try to look at. Also doing some advocacy and lobbying around it to our different governments and see how best they can implement results-based funding in our different countries. The previous speaker also mentioned another key important point where we need to collaborate more than ever. Youth-led organizations, CSOs, they need now to come together and work together, build coalitions. You realize now working alone, it's not viable anymore. With the type of funding that's there, the globe is competing for a small pool of funding that was there because the stock orders from the USA, the PEPFAR that were bringing in large sums of money, they've stopped and we are now competing for a small pot of funding. So we need to be organized, we need to collaborate on our work that you are doing. So regional collaboration is needed as well. Someone from East Africa partnering with organization from Southern Africa, West Africa, to come together and work together, that's really needed as well. I think that point from the previous speaker, it's really critical if you want to bridge that gap. When you work together, work in consortiums, it also can help for youth-led organizations. The previous speaker also mentioned an important issue to talk about government funding as well. We really need to do a lot of advocacy around government funding the projects for young people that are done in communities. The Abuja Declaration, it's a very important regional framework that we can try to capitalize on to ensure that, for example, Zimbabwe, they should ensure 15% of the national budget is channeled towards the Ministry of Health. Within that 15%, how much is it going towards financing sexual reproductive health services for young people? Within that 15%, how much is being funneled towards providing family planning services for young people, youth-friendly services for young people? So that's very key. We need a lot of advocacy around it. That's a huge gap there. We need to start looking at, is the government providing that 15% of the national budget to health? And within that 15% of the national budget, how much is going towards sexual reproductive health for young people, HIV and AIDS programming, youth services for young people? So those are the areas that we need to look at, take up responsibility and do a little bit more of funding around HIV and AIDS programs for young people. So the Abuja Declaration can help us. We also have the ESA ministerial commitments on health and education. That's another regional framework that we can also use to leverage on government and hold them account to the decisions that they have made, to the commitments that they've actually made. We also need to sit down and talk to donors. Those strict requirements that they put up across, it's not suitable for small organizations, for youth-led organizations, for youth groups. So we need donors to simplify funding. You realize donors, they need audited accounts for an organization that haven't held a maximum of $10,000 annual budget. So you find out they can't afford to do auditing, but they require an audited accounts. They don't have all those policies that put. So we need to sit down with the donors and say, look, these days times have changed, and youth-led organizations, grassroots organizations, they are the ones making the huge impact. Why not fund them directly? Why not capacitate them? Why not simplify funding? Put in small pool of funds rather than having those $150,000 budgets. Why not have the $30,000 budget, $20,000 budget, activity-based
Thank you.
funding? I think that will work. that will work more for youth-led organizations within the grassroots level. So we need to sit down with the big donors, bring them all, the Ford Foundation, the HIVOS, all those big donors. We need to take them together and have a discussion with them. How best can they simplify funding? Coalition building.
Can we summarize? Can we summarize, please?
Okay. Yes. So yeah, another issue is to look at the intersectionality of issues. We now don't need to rely more on HIV programming alone. How is HIV cutting across with climate change? How is HIV linking with agriculture and livelihoods? Those areas that have got a little bit more funding, how can we leverage on that? We don't want to just program on sexual reproductive health programs only. We now need to have a comprehensive approach to it, bringing in the livelihoods aspect, the SRI-HR aspects, bringing in the policy, governance, and advocacy side. Then we have a comprehensive package that we can actually sell to the donors. And lastly, as CSOs, we need to be proactive ourselves. We don't need to just wait for donors to put out a call for proposal. We need to be proactive. What's your niche as an organization? What's your selling point? What's your unique offer that you can give out to donors and say, look, I have this and we are looking for funding. So we also need to be proactive about it. Thank you so much. Okay.
Thank you, Maxwell, for raising the voices of young people and sharing with us some of the approaches that we could take in improving how CSOs focusing on youth programming can actually elevate. And I want to mention that, Maxwell, we want to change the narrative. Someone mentioned that we cannot do business as usual. We don't want now a conversation where donors are coming on board to determine what we should do. It should be the other way around, that now we are supposed to tell them this is what we need and that's what they would fund. And then we don't also want to promote donors because as much as they contribute to the development of our country or the development of these sectors, we have seen what could happen. Their funding is not sustainable. It can go and come anytime. And we are saying that how can we even promote local donors? We don't want to do now with those external donors because anything can actually happen. And then you spoke about programming and designing programs that focusing on young people. Of course, globally, the population of young people takes the biggest chunk in almost every country. And so we have to design programs that are responsive to youth needs. However, we have also to be mindful that as much as we are designing programs that are focusing on youth needs, there are things that will generically be availed. And it is also for us to shift the mindset of a young person, because sometimes we as young people, we speak from the perspective that everything has to be ours. And then we forget that when we start designing programs, some of them may generically be provided and a few or specific programs may be provided to respond to some issues that are affecting young people. So as we engage and negotiate around funding programming, we have to go in with a diverse mind of designing something that may work for young people and people beyond who may not really be young people. But thank you for sharing your insights. Would like to open up the session for questions to our listeners, and we don't have a lot of time. I'm not sure if we have questions in the
we do have Hattas Yumna. You can proceed and ask your question.
Hi, good morning, everybody. My name is Yumna Hattis. I'm the lead for human rights and gender justice at Frontline AIDS on the USG response. And my it's probably more of a comment than a question. I'm totally in agreement that we need to start looking at getting away from the dependency syndrome of donors because it's just not sustainable. But I do want to say, I think we might want to take two things into consideration. Yes, the Abuja Declaration, which is very important. We need to be holding countries accountable, but also we need to be very cognizant of the anti-rights movement and how it's disabling our ability to work within the sector that we have. And the Maputo Plan of Action is something that many countries have signed on, but have we held them really accountable for what they promised to do in their countries? Because now SRHR and DEI is undergone. And we do know that the US is still implementing the global gag rule, even though it's quietly being done. And so you'll find that organizations will not be doing certain things because they are getting money back, but they have to do it under the guise of the global gag rule. So please, I think we need to start thinking and mobilizing around that. And the anti-rights movement is moving in on us. The Geneva Declaration, all of those things, we need to really be aware of it. And just remember, our religious leaders are being targeted. Thank you.
Sure. Thank you for that submission. I think someone will expound on it. One of the panelists can expound on it, but we have another hand up. Is that Hattas?
Now that was me. I just spoke earlier.
Oh, okay. So do we have any other hands up? Need to check.
No, but there
Lizzie,
is
do we
a
have any
question.
other?
No hands,
Okay.
but there's a question in the queue. Oh yeah, I've seen. Okay, somebody had a hand up. Anyway, but we have a question at the Q&A. Yes, we do have Ifoma Okoye. So Ifoma, you can unmute.
Okay. Did I succeed in unmuting? Yes.
Yes.
Oh, I mean, it's been a very reverberating. I'm a professor Okoye. I'm an emeritus professor of radiology at in Nigeria and in the NCD space, and doing quite a lot of work in different other public health issues. So I'm very, very interested. And what really caught my attention during the session is the reference to working as a continent rather than different countries. I've always believed in that. Is there any way we can, as a group that are coming together to look into this issue and nip it at the board before it gets out of hand, to whatever strategies we are putting in place, to be thinking continental rather than individual country, implementing different programs here and there, especially in this being able to come up with HIV drugs. We've built capacity over the years. I know the volume of clinical trials is still very low, especially in drug development. But when we begin to work as a continent, there is so achieve together. That's what I want to quickly contribute. Thank you so much.
Sure, thank you. We lost you a bit, but I think we were able to pick some of the insights that you were sharing. We agree that working together is something that we really need to embrace currently. And I think there's some new developments that are coming in from the African Union. I think 2 months ago, sometime, I think there is a report that was released by the African Union around the 24th Common Medicines in Africa. And they will be engaging countries that have core advantages on each of the products. And so they will be working with them to boost production and also looking into global policy related issues around drug production, because we have challenges to do with technology. We have challenges to do with patents, where certain drugs cannot be manufactured in Africa. So as we speak about certain elements, there are also challenges that are rotating around them that institutions, governments need to get in and start negotiating, with the leaders within those sectors to be able to ease on how we do business as a continent. We also spoke to a collective effort from civil society and other stakeholders. If you're talking about private sector, and the private sector role, for example, currently is very important, because when we look at our out-of-pocket expenditure on average in Africa, I think it ranges between is it 15 to as high as 48% in Africa, meaning that our people, our population, most of the time moves out to go and pay for a service. And where do they go? They go to a private drug shop, they go to a private clinic, they go to a private pharmacy, they go to a private hospital, which means that if we negotiated well with the private sector, they could be able to give us affordable services where everyone can afford, but also private sector that is not in the health sector. Someone spoke about MTN and others, that we can learn with when we start having conversations around HIV, health, financing HIV, and any other health-related issue. So I think this conversation serves to kind of help us reflect on what is working, but we're also meant to shift to hold this conversation and push it to other platforms where these conversations are still happening. If it's at government level, are you engaging with your politicians? Are you engaging with your president? Are you engaging with your technical people? So I think the lessons we're picking from here are meant to inform our interventions in country. At this point, I want to
Quick one, Diana.
list.
So
Yeah.
we have George's hand up. We can take, I think,
Okay.
one more question and
One
then
hand? Oh,
yeah.
fine.
Yeah.
Yes, George, please, you can come through.
Okay. Thank you. So mine is an addition. I think we should, as Africans, or should also invest a lot to the people who are doing the research of getting the cure, so that we cannot rely, on these things. So I think it would be good also if we invest a lot in that in Africa. Thank you.
Thank you. You're very right. Indeed, it's one of the areas that are always underfunded here in Africa. If you looked at all the country budgets, research is on the low, something that we should prioritize, because it takes us ages to even establish a vaccine that would work for COVID for some people, things like mpox, and so we really need to invest in research and development. We would like to move to close this session, and we want to first of all appreciate people who have been able to share questions, but we want to invite back our speakers to have every one of them say a parting shot, summarize and share with us a parting shot in regards to the conversation that has happened, lessons that have been shared, like what do we go with from this conversation? Can start with Maxwell. What is your parting shot in regards to this conversation? What do you want people to go away with?
Yeah, thank you so much. For me, I will re-emphasize, I think, the previous speaker, someone made a contribution on collaborating. I think we need to come together as a continent, work together where that we are doing advocacy, it's accountability, we are looking for funding. We need to come together, get organized. I think that will help us in terms of moving forward and sustainability of our work. So we really need to collaborate. We need to get organized. Yeah.
Thank you so much, Maxwell. Petrida, what is your parting shot? What do you want us to go with from today's conversation?
Thank you so much, Diana. So ideally, my parting shot is to ensure that we mobilize enough of domestic resources so as we can have sustainable collective efforts to curb challenges of donor shrinking funding and to create a platform for sustainability. Thank you.
Thank you, Petrida. Chimwara, what is your parting shot?
Thank you, Diana.
Yeah, please come through.
Thank you very much, Diana. I think the campus model is a very innovative approach to collaboration, linking and learning, and sharing best practices. And I think it's a model that across Africa we need to start looking at and making sure that we are able to use such platforms that go across the region to make sure that we push the same agenda, especially around domestic resource mobilization. Thank you.
Sorry, just to make sure, Munya, can you hear me?
Yes, I can hear you.
Let's do your parting shot. Sorry, I think we lost Diana.
Oh, okay. Thank you very much for the opportunity to speak. And I think the campus model is an innovative approach to making sure that there is South-to-South collaboration, leveraging on best practices, technical expertise across Africa, and regional advocacy. That is key to make our governments accountable for resources allocated to health through the fiscus and other ring-fence resources. And I think it provides, again, an opportunity for us to come together as an African continent to make use of indigenous knowledge systems and bring home-based solutions to global problems. Thank you.
Thank you. I know Dr. Kate Tulenko is here to join. Doc, if you can hear me, there was a question on how can we act as a continent and, start mobilizing as a region and not individual countries. I don't know whether, Doc, you can just take that question when you give us your parting shot.
Yes, thank you so much. Can you hear me?
Yeah, loud and clear.
Perfect. So this is a gloves off moment for Africa and all of its countries. And it's actually a unique opportunity to break from the way things have been done in the past. And this really is the opportunity to have a HIV AIDS level gathering together of communities to act up against corruption, to claim the resources that are available. Africa is a rich continent. The countries have plenty of money for the health needs of its people. It's just unfortunately taken away. And I think by addressing the corruption, having the lean operations and the regionalization I mentioned in my speech, that's how we can make sure everyone gets the care that they need.
Thank you, Doc. Appreciate it for you waking up this early. Petrina, have you given your closing remarks? I just don't want to miss anybody out.
Yes, I did.
Okay, perfect. So ladies and gentlemen, I think that's all the speakers, and I appreciate it. I know Dr. Maurice had to log off. Thank you very much for just giving us an hour and a half, actually, an hour and more than half, just having this crucial discussion. I know we cannot take all questions right now, but of course, we'll be having more discussions on the ENASO in collaboration with the partners to just host another version of this. And let's be honest, it's a time where we can't get tired of having such kind of discussions and paving way on how we can move forward and just figuring out what to do next. So on behalf of I don't know, Diana is back. Diana, you're here, right? I can see you're back.
Sure, sorry, we lost.
No worries. It happens, but I'm just excited it happened when we're closing. But on behalf of ENASO and all the other partners, we do appreciate the support from HF. And thank you, Diana, for moderating this session. I know we're 6 minutes past, so I'll just let you say one remark and close the discussions. Thank you, Diana.
Sure, thank you, Lizzie, for giving us the opportunity to moderate this conversation. What I can say is that this is the current global conversation happening everywhere. So having such conversations, I think, should be continuous because it helps us accelerate and ensure that all what is discussed is put in place, but it also acts as a platform for accountability. We've spoken about commitment, we've spoken so many things that if we discuss and don't put them in action, like nothing that will be done. So for me, I appreciate these kind of platforms where we are picking lessons, working models. Let us be able to share also in our respective forums where we think we can have an influence to have this scaled up. So yeah, we appreciate everyone who looked into this conversation, and every information that has been shared, I think, should be put into best use. Thank you.
Thank you very much. Ladies and gentlemen, do have a great morning for Dr. Kate and great afternoon to all of you. Appreciate it. Bye.
Bye-bye. Thank you, everyone.